Hi everyone, welcome back to your channel I Love Pharmacology. In this session, let us learn about a very important points from general pharmacology, autonomic nervous system, autocoids, peripheral nervous system, CNS and the diuretics. So let me start with the general pharmacology. So what are the physiological antagonists you know? So what do you understand by physiological antagonist? So these are the antagonists, they act on the different receptor on the same system. So they act on the different receptor on the same system to produce the opposite response. So here you have an example of, for physiological antagonism, the example is histamine, adrenaline, histamine, omeprazole, and insulin and glucagon. So histamine will cause bronchoconstriction, whereas adrenaline will cause bronchodilation. Histamine increases the gastric acid secretion, omeprazole decreases the gastric acid secretion. Insulin will decrease the glucose levels, whereas glucagon will increase the glucose level. So what is the other name for physiological antagonism? It is also called as functional antagonism. Functional antagonism. So next, coming to the, which are all the receptor which act very fastly. So in the transducer mechanism, it is the ion channel which has got the fastest action. So which receptor has got the slowest action? So it is the nuclear receptors. Nuclear receptors. So what do you understand by pharmacokinetics? Pharmacokinetics is a study of the ADME. It stands for the absorption. D stands for distribution. M stands for metabolism, and E stands for excretion. So these are the four components of the pharmacokinetics. So what do you understand by bioavailability? It is a fraction of the drug which gets into the, it's a fraction of the drug which gets into the systemic circulation. It gets into the systemic circulation in an unchanged form. So this is the definition of the bioavailability. It is a fraction of the drug which reaches the systemic circulation in an unchanged form. So how it is represented? Formula: area under the curve for oral divided by area under the curve for intravenous route. So which route has got 100% bioavailability? So which route has got 100% bioavailability? It is the intravenous route. So sublingual route examples. So you can use glycerol trinitrate as well as the buprenorphine through sublingual route, as it will bypass the first pass metabolism. So which are the example for the drugs which are given through nasal sprays? So you can use antidiuretic hormone like desmopressin, GnRH analogs, and the calcitonin. So what is the relationship between the propanacid and the penicillin? So propanacid is a uricosuric agent. It is a uricosuric agent. That means it increases the excretion of uric acid. But propanacid will compete with the penicillin and inhibits the penicillin secretion. Thereby, it increases the penicillin action or effectiveness. So next, coming to, there are two order of kinetics, that is first order kinetic and zero order kinetic. So zero order kinetic is also called as saturation kinetic, as the enzymes get saturated. So what are the examples for zero order kinetics? So you can remember it as the mnemonic 0 watt power. So W stands for warfarin, A stands for aspirin, A stands for alcohol, T stands for theophylline, one more T stands for tolbutamide, and P stands for phenytoin. So next, coming to the cevimeline. So cevimeline is a M3 receptor agonist. Basically they are used in the treatment of Sjogren's syndrome, where it is associated with the dryness of the high, as well it will increase the secretion, increases the secretion. So what is derifenacin? So derifenacin is a M3 receptor antagonist. Basically they are used for treatment of urinary incontinence, urinary incontinence. So where do we use timolol and the cartiolol? So these are the beta blockers which are helpful in the treatment of the glaucoma, helpful in the treatment of glaucoma. So next we have a acetazolamide and dorzolamide, which are the carbonic anhydrase inhibitor. This is also used in the treatment of glaucoma. They are basically used in the form of topical route in the form of eye drops. So next we have a clonidine and apraclonidine. These are alpha 2 agonist. Again, these are used in the glaucoma. And pilocarpine is a M3 agonist. Again, it can be used in the glaucoma. So what we learned for glaucoma, you can use the beta blockers, you can use carbonic anhydrase inhibitors, you can use alpha 2 agonist, you can use M3 agonist, and also you can use the PGF2 alpha analog. These are the prostaglandin analogs, and the most common is the latanoprost. So these are the first line drugs. Prostaglandin analogs are the first line drugs used in the treatment of glaucoma, and latanoprost is associated with the side effects such as iris pigmentation. They are associated with macular edema, etc. So next, what are the anticholinergic agent which can be used for treatment of the COPD and the asthma? So we have a ipratropium bromide, tiotropium bromide. These are the M3 receptor antagonists. These are used in the form of inhalational route in the treatment of COPD and asthma. Next, let us see the uses of muscarinic antagonist. So CVS, it can be used to treat the sinus bradycardia. The drug used is the atropine. So in the eye, since it causes mydriasis, passive mydriasis, it dilates the pupil for fundoscopic examination. So in adults, we use a shorter acting agents like tropicamide and the cyclopentolate. Whereas in case of the children's, we use the atropine for fundoscopic examination, as the tone of the ciliary muscle is very high in case of the children's. So what are the CNS uses? They are used for motion sickness. The drug is the iosine, which is also called as scopolamine, They are used in the form of transdermal patches. And one more use of CNS is they are used for drug-induced Parkinsonism, where there will be increase in the cholinergic activity. To reduce the cholinergic activity, we use the centrally acting anticholinergic agents such as benzhexol, piperidine, and benztropine. And also you can use the antihistaminics, that too first generation antihistaminics. The example are promethazine, which has got high central anticholinergic activity. So RSUs, coming to the RSUs, respiratory system. So muscarinic antagonist or derivative can be used in the treatment of COPD and asthma. Examples are ipratropium bromide and tiotropium bromide. And GI related uses is they are used for treating abdominal pain related to irritable bowel syndrome, which acts as antispasmodic agents. Example is dicyclomine. Next, you have a urinary tract uses, that is in case of the overactive bladder, we can use a soft bladder. The mnemonic is soft bladder. S stands for solifenacin, O stands for oxybutynin, and F stands for fluoxetine and festorodin, and the T stands for tolterodin, and D stands for derifenacin. These are the vesico-selective anticholinergic agents. So next we have a pre-anesthetic medication. We use atropine derivative like glycopyrrolate and iosine to decrease the secretions, just before anesthesia. So what are the drugs which are used for smoking cessations? For smoking cessation, we use three groups of drugs. One is the varenicline, next is the bupropion and nicotine. Bupropion is a antidepressants, which is a antidepressant, and Varnaclin is the most effective drug to relieve the smoking cessation. So next we have a drug from the skeletal muscle relaxant, that is the atracurium and cisatracurium, undergo spontaneous or non-enzymatic degradation. Non-enzymatic degradation. It is also called as Hoffman elimination. Hoffman elimination is associated with atracurium and the cisatracurium. So which is the non-depolarizing skeletal muscle relaxant, which is used to reverse the action. So actions of non-depolarizing skeletal muscle relaxants such as the D-tubocurarin, etc., can be reversed by neostigmine, which is an anticholinesterase. Then we have a mivacurium. So mivacurium is a shortest acting non-depolarizing neuromuscular blockers. Next we have a sugammadex. What is sugammadex? Sugammadex is a drug which is used to reverse the neuromuscular blockade produced by especially the rocuronium and the vecuronium. So which is the skeletal muscle relaxant which can cause the malignant hyperthermia? So malignant hyperthermia is caused by succinylcholine. So what is the drug of choice for malignant hyperthermia? It is dantrolene sodium, which is a ryanodine receptor antagonist. Next we have a succinylcholine apnea. So succinylcholine apnea occurs in a atypical pseudocholine esterase, or if there is a deficiency of the pseudocholine esterase. Thereby what happens to succinylcholine metabolism? Succinylcholine metabolism will reduce and succinylcholine will act for long period, and which causes the paralysis. So this is called as succinylcholia, where it leads to difficulty in the breathing. It is mainly due to the presence of the atypical pseudocholinesterase or absence or deficiency of the pseudocholinesterase. So otherwise the succinylcholine will be degraded very quickly in a seconds of time, and in case of atypical individuals, so this can lead to succinylcholine apnea. So what is hemicolonium? Hemicolonium blocks the choline intake into the presynaptic nerve terminals, where it is required for the synthesis of the acetylcholine. So vesamicol is another antagonist which blocks the acetylcholine transport into the synaptic vesicle in the presynaptic junction, in the presynaptic nerve terminals. Then we have a botulinum toxin and beta bungarotoxin, which will decrease the release of the acetylcholine into the synaptic cleft. We have the uses of botulinum toxin. So what are the uses of botulinum toxin? So it is used as a local injection, where it can be used for blepharospasm, or mainly it is used for cosmetic purpose. So the uses of blepharospasm, spasticity, urinary incontinence, squint, hyperhidrosis, migraine prophylaxis, forehead wrinkles, and the siluria. So next, coming to the hydrophonium test. What is hydrophonium test? Hydrophonium test is done to differentiate the cholinergic crisis and the myasthenic crisis. So if you give a hydrophonium test, which is a short acting anticholine esterase. So what happens when you give, if the muscle weakness improves, that is myasthenia gravis. If the muscle improvement is not seen, that means if there is a worsening of the muscle weakness, then it is due to cholinergic crisis, due to the excess of acetylcholine activity. So next is myasthenia gravis. So myasthenia gravis, as you know, it is an autoimmune disorder where there is an antibody against the NM junction. So the treatment is to increase the acetylcholine levels. You use anticholinesterases, that is neostigmine and the pyridostigmine, and neostigmine is preferred. So what is the reason for preferring the pyridostigmine? Pyridostigmine is preferred because of their long acting nature and it requires less frequent administration. So what are the drugs which are used for Alzheimer's disease? So we can use DRG, that is donepezil, galantamine and rivastigmine, and also you can use memantine, which is a NMDA receptor antagonist. Next we have a reversing non-depolarizing. Whenever you want to reverse the non-depolarizing neuromuscular skeletal muscle relaxant, so along with the neostigmine you also give the atropine. The reason means when neostigmine is given, it will increase the activity on the muscarinic receptor as well, apart from action on NM receptors. To counteract the muscarinic action, you use atropine, which is an anti-muscarinic agent. Thereby it prevents the adverse consequences due to muscarinic action. So next, coming to the agonist and antagonist related to the autonomic nervous system. So the alpha 1, the agonist is phenylephrine, and alpha 1 blocker, it is the prazosin. So alpha 2, which is located in the presynaptic neurons, the clonidine, which is alpha 2 agonist, and yohimbine is a alpha 2 blocker. Beta 1, we have a dobutamine is agonist, and atenolol is a cardioselective beta blocker. This is the cardioselective beta blocker. Then we have beta 2 agonist, that is salbutamol, which is used in the treatment of the asthma, and butoxamine is a B2 receptor antagonist. Please always remember atenolol, whether it is atenolol or propranolol, they are contraindicated in the treatment of bronchial asthma. But atenolol, being the selective beta 1 blocker, it can be preferred in case of bronchial asthma, but there should be caution. Is that clear? Okay, fine. So we have a beta 3 agonist, that is mirabegron, which is used to treat the overactive bladder. So what are the uses of adrenaline? Adrenaline is a sympathomimetic agent. They are used for the treatment of anaphylactic shock, cardiac arrest. They are added along with local anesthetic to increase the action of local anesthesia, to decrease the dose required for local anesthesia, and to decrease the systemic side effects related to local anesthesia. So to treat anaphylaxis or anaphylactic shock, so adrenaline is a drug of choice, is the adrenaline. And what is the dose which is used? The route is intramuscular. You use 0.3 to 0.5 ml in a dilution of 1:100. If you want to use 1:10,000, that means you are injecting through intravenous route or endotracheal route or intraosseous route. Or if you want to give it through local anesthesia, that is local anesthesia, it has to be dilated for 1:50,000 to 1:2 lakh. So remember, drug of choice for anaphylactic shock is adrenaline, and it is administered through intramuscular route. The dose is 0.3 to 0.5 ml and the dilution is 1:1000. So asthma, we use a beta 2 agonist like salbutamol, terbutaline, and they are also used for the premature labor, to prevent the premature labor. So these are also called as, the another name is tocolytics. So we have a nasal decongestant. Again, these are the sympathomimetic drugs. We have phenylephrine, methoxamine, xylometazoline, and the ephedrine. So one of the adverse consequences of using nasal decongestant for prolonged time is the atrophy of the mucosa. Atrophy of the nasal mucosa, which leads to anosmia, loss of smell sensation. So next we have which is the longer acting beta 2 agonist which are preferred in the bronchial asthma. So we have salmeterol is a longer acting agent when compared to the salbutamol. Then we have a dobutamine, which is a beta 1 agonist. They are preferred in case of cardiogenic shock. And also you can use dopamine in case of the cardiogenic shock based on the dose dependent action. So what are the adverse effects of the salbutamol? So salbutamol can cause three T's, that is it can cause adverse effects such as the tachycardia, T stands for tremor, and the changes in the T wave. So these are the side effects of the beta 2 agonist. Next we have a clonidine. Clonidine is a alpha 2 agonist and they are used for treatment of hypertension, migraine prophylaxis and treatment of the hot flashes. We have one more drug under alpha 2 agonist, that is lofexidine, which mainly used to decrease the symptoms of opioid withdrawal, that is lofexidine. Then we have a phenoxybenzamine and phentolamine are the non-selective. These are the non-selective alpha blockers. Phenoxybenzine is used in the treatment of pheochromocytoma. In case of pheochromocytoma, you need to first give the alpha blockers followed by beta blockers. So where do we use prazosin? Prazosin is a drug of choice for BPH associated with hypertension. So if there is only BPH, you will use tamsulosin, which is a alpha 1 antagonist only in BPH. If BPH is associated with hypertension, you use the prazosin. And also please remember, prazosin is a drug of choice for scorpion sting poisoning or scorpion sting bite. So what are the adverse effects of alpha blockers? Alpha blocker will lead to failure of ejaculation. So what are the uses of propranolol? Propranolol being a non-selective, it is a non-selective beta blocker. They are used in the treatment of angina, hypertension, arrhythmia, anxiety, to treat tremors, glaucoma. That is, we use a cardioselective beta blockers like timolol, cartiolol, etc. in migraine prophylaxis, and also they are used to treat the sympathetic activity which are increased in case of thyrotoxicosis, and glaucoma use the timolol. So what are the adverse effects? It can cause bronchoconstriction. Since it is a beta 2 receptor blocker, it causes bronchoconstriction and hypoglycemia. So propranolol is totally contraindicated in the patient who are having bronchial asthma because it causes bronchoconstriction. Next we have a labetalol. Labetalol is a drug of choice in case of the pregnancy. It is a hypertensive drug of choice in the pregnancy. We have a carvedilol. So both labetalol and carvedilol, they block alpha as well as the beta, and carvedilol is preferred during the treatment of cardiac failure. So which is a drug which causes first dose effect? That means where it causes postural hypotension. Suddenly when the patient gets up from the bed following the intake of the tablet, it can cause the postural hypotension, giddiness, etc. So example is the prazosin, which is a alpha 1 blocker, has got first dose effect. The next we have a 5-HT1 receptor agonist. We have triptans and buspirone. So triptans, they are used to treat migraine, whereas the buspirone is used to treat the anxiety. So we have next 5-HT3 antagonist. We have ondansetron, palinosetron, granisetron. Basically they are used for the treatment of cancer therapy, nausea and vomiting, or it is called as chemotherapy induced nausea and vomiting, radiotherapy induced nausea and vomiting, and post operative nausea and vomiting. So what is 5-HT4 agonist? 5-HT4 agonist activity is shown by metoclopramide, cisapride and the tegacide. Metoclopramide is a prokinetic agent. So coming to the ergot alkaloids, under ergot alkaloids you have got ergotamine, dihydroergotamine, ergometrin, which is used for prevention of postpartum hemorrhages, and we have a bromocriptine, basically used to treat the Parkinson's disease and diabetes mellitus, and a methotrexate used for carcinoid syndrome and migraine prophylaxis. So both bromocriptine, methotrexate, all this belongs to ergot alkaloids. So coming to the migraine prophylaxis. So this is very very important. In case of migraine prophylaxis, the mnemonic what you should remember is the ABCD. So A stands for anticonvulsants, B stands for beta blockers, C stands for calcium channel blockers, and D stands for antidepressants. So anticonvulsant you have got valproic acid, gabapentin, topiramate. Beta blocker you have got propranolol is the most commonly used drug for migraine prophylaxis, and we have verapamil under calcium channel blocker, we have amitriptyline under tricyclic antidepressants. So what is the action of sumatriptan? So sumatriptan is the drug which is used in the treatment of acute attack of migraine, and they act by a selective 5-HT1D1B agonist, and it causes vasoconstriction. So that's why, since it causes vasoconstriction, they are contraindicated in patients who are having hypertension or CHD. So one of the newer prophylactic agent for the treatment of newer prophylactic agent for migraine prophylaxis is the calcitonin gene related peptide receptor antagonist. Here you have GPANTs, that is obrogepant and the rimagepant. So basically they are used for oral acute attack. Then next we have a anti-CGRP receptor monoclonal antibody. Again, these are used for prophylaxis. So please remember, this CGRP receptor agonist, that is GPANT, is used for acute attack through oral route, that is the ubrogepant and rimagepant, whereas the anti-CGRP receptor monoclonal antibody is used for prophylaxis of migraine. So here they end with MAB, that is a monoclonal antibody. We have erinumab, galcanezumab, fremanezumab, and eptinezumab. So all these are used for prophylaxis. So first three drugs are used subcutaneously, and eptinezumab is used by slow IV infusion. We have one more group of drug which is used for prophylaxis, that is called as 5-HT1F agonists. They are called as DTANs. The example is lasmiditan. Basically these are the blockers of CGRP release. It inhibits the release of CGRP, and the advantage is when compared to other drugs under migraine, it does not produce vasoconstriction, and it is used for oral acute attacks. So DTANs and GPANs are used for acute attack, whereas the monoclonal antibody is used for the prophylaxis. Is that clear? So what are the drugs which are used for treatment of the migraine? So migraine we use drugs like a simple analgesics, anaesthetics, stronger anaesthetics, ergot, triptans, and the antiemetic agent to treat nausea and vomiting. So what are the advantages of the second generation antihistaminics? So second generation antihistaminics had advantage of, since it do not crosses the blood-brain barrier and it does not enters the CNS, so it has got no CNS depression action, no sedation, no anticholinergic effect, and inhibits the late phase allergic reaction, and it is highly selective for H1 selectivity. So all this will be the opposite in case of first generation crosses the CNS, it leads to sedation, it has got the anticholinergic activity, etc. So what is beta histamine? So beta histamine is a H1 selective histamine analog used in the treatment of Meniere's disease. We have a classification to remember from the H1 antihistaminic, that is the first generation, which are highly sedative since it crosses the blood-brain barrier. So we have a first generation, that is diphenhydramine, dimenhydrinate, promethazine, and these are having a strongly anticholinergic action. They can also be used in the treatment of motion sickness. So motion sickness, the drug of choice will be the iosine. And second generation are less sedative because it does not cross the blood-brain barrier. The example are cetirizine, leocetirizine, and fexofenadine. So next, coming to the prostaglandin analogs. So that is the antagonists. Prostaglandin E2, we have a dinoproston and gemetoprost. That is the prostaglandin E2. They are available in the form of vaginal gels, oral tablets, IV preparation, extra-amniotic solution, and gemiprost is available in the form of vaginal pessary. Basically, the uses of it are they are used for labor induction, cervical ripening, and the abortion. So we have one more prostaglandin, F2 alpha analog, that is dinoprost, again used for induction and abortion. We have a very important drug, that is 15-methyl prostaglandin F2 alpha, that is a carbaprost used for postpartum hemorrhage control and the abortions. So termination of pregnancy can be made with the help of antiprogesterone, that is the mifepristone 3 tablets followed by 2 tablets, and misoprostol 2 tablets. It should be administered up to 49 days. So up to 49 days for the termination of pregnancy, you can consider mifepristone and the misoprostol. We have a topical prostaglandin F2 alpha analogs which are useful in the treatment of glaucoma, that is the latanoprost, travoprost and the bromoprost. So these are the first line drugs. And we have a prostaglandin even analog, that is the alprostadil, which are basically used for maintenance of the ductus arteriosus and for impotency treatment. For closure, which are all the drugs which are used? For closure, you use indomethacin, ibuprofen, aspirin, etc. We have a epoprostenol, that is prostaglandin I2 analog, which is used to prevent the platelet aggregation, helpful in pulmonary hypertension and peripheral vascular diseases. So NSAIDs, what are the mechanism of actions? So non-steroidal anti-inflammatory drugs inhibits the cyclooxygenase activity, thereby it decreases the prostaglandin synthesis, which are the inflammatory mediators. So what are the actions of aspirin? Aspirin irreversibly inhibit the COX enzyme activity, both COX-1 and the COX-2. So what are the selective COX-2 inhibitors? We have celecoxib, etocoxib and paracoxib. So here the advantage is less GIT side effects, but the disadvantage is it is pro-aggregatory. That means it increases the activity of thromboxane A2 and decrease the prostacyclin production. So this is very cardiotoxic in nature. We have NSAIDs. Since it inhibits the thromboxane A2, it prevents the platelet aggregation, and also since it inhibits the prostaglandin I2, it increases the risk of platelet aggregation. This is the reason for selective COX-2 inhibitor drugs. So these are the property exhibited by the selective COX-2 inhibitors. So they increases the basically selective COX-2 inhibitor increases the thromboxane activity and decreases the prostacyclin activity. So whereas when you give NSAIDs, it will inhibit both thromboxane A2 activity as well as PGI2 activity. Thereby what happens? It prevents the platelet aggregation. One such example is the aspirin. Thereby it has got anti-platelet action. So next, coming to the aspirin dose dependent actions. So aspirin being a NSAIDs, it irreversibly blocks the COX enzyme. So antiplatelet action is produced at 75 to 325 milligram. Analgesic and antipyretic activity is seen between 300 to 600 milligram, and anti-inflammatory activity is seen at 3 to 6 gram per day. So where do you see the race syndrome? So whenever children is given with the salicylates or aspirin, if the children has got fever, it will lead to race syndrome. So if the children has got viral fever and if you administer the salicylic acid or aspirin, especially in the children below 12 years of age, it causes race syndrome, which is a hepatoencephalopathy. So next we have a condition where you can use alkalization of the urine to remove the toxicity. In case of aspirin overdose, as you know, aspirin is a weak acidic drug. For the acidic drug to get excreted from the urine, you need to alkalize the urine with the help of sodium bicarbonate. So next we have how the interaction will occur and decrease the response of the other drug. So aspirin being a NSAIDs, it will blunt the diuretic action such as furosemide and thiazide. So this will decrease the efficacy in case of hypertension patient. So aspirin at low dose, please remember, very important, aspirin at low dose will act as a antiplatelet action by inhibiting the thromboxane A2 activity in the platelets. So ibuprofen and indomethacin are the stronger anti-inflammatory agent, and also these are the agents which are used for medical closure of the patent ductus arteriosus. We have a selective COX-2 inhibitor as we discussed earlier. It decreases the endothelial production of prostacyclin production and does not affect the platelet thromboxane activity. Thereby, it behaves as a prothrombotic agent and increases the risk of cardiovascular condition. So what is the antidote for the paracetamol poisoning? So the antidote is the N-acetylcysteine, which is the antidote which will going to replenish the glutathione stores, which is a toxic metabolite responsible for paracetamol poisoning. So we have a N-acetyl para benzoquinine amide, that is NABQ high. So what will happen to the chronic alcoholic? So chronic alcoholism will going to stimulate the or induce the microsomal CYP2 microsomal enzyme, that is CYP2E1, and it increases the concentration of the N-acetylcysteine para benzoquinine if paracetamol doses increased in alcoholic patient. So what is the drug of choice for rheumatoid arthritis? The drug of choice for rheumatoid arthritis is the methotrexate. Methotrexate acts by inhibiting the dihydrofolate reductase enzyme. So under DMRDs, you have classified the drug into non-biologicals and biologicals. Methotrexate is a drug of choice. The next we have azathioprine, cyclosporin, sulfasalazine, chloroquine, leflunomide, and these are all the immunosuppressants. Leflunomide acts by inhibiting the dihydroorotate dehydrogenase enzyme. So what is anakinra? Anakinra is a drug which is used to treat the rheumatoid arthritis. Their action is receptor antagonism towards the interleukin 1. So anakinra is an interleukin 1 receptor antagonist. Interleukin will act as an inflammatory mediators. So what is the dose of the methotrexate in rheumatoid arthritis? The dose of the methotrexate in rheumatoid arthritis is 7.5 to 50 milligram weekly. Please remember. And methotrexate inhibits the enzyme called as dihydrofolate reductase enzyme activity. And side effects of methotrexate is it can depress the bone marrow. It can lead to folic acid deficiency. So that's why you need to supplement with the folinic acid. We have a chloroquine. Chloroquine also used in the rheumatoid arthritis treatment, but long-term use has led to the deposition. Long-term and high dose has led to the deposition of fluoroquine in retina, leading to retinal damage and corneal opacity. Then next we have a leflunomide, and another faster acting. This is the fastest acting disease modifying anti-rheumatoid drug. They act by inhibiting the dihydroorotate dehydrogenase enzyme. So what are the drugs which are used for the treatment of the acute gout? So please remember, in the treatment of the acute gout, we use three drugs, that is the non-steroidal anti-inflammatory agent, colchicine, and the glucocorticoids. And colchicine is the fastest acting drug here, Whereas to treat the chronic gout, we use two types of drugs, that is two groups of drugs, that is the uricosuric agent, which increase the excretion of uric acid and which can decrease the synthesis of the uric acid. So under uricosuric agent, we have propanacid, sulfenpyrazole. Under synthesis inhibitors, you have allopurinol, febuxostat. So please remember, allopurinol is a drug of choice for in case of chronic gout. And colchicine, as we discussed earlier, it is fastest acting agent. It inhibits the chemotaxis activity, thereby it inhibits the urate crystal formation as well as inhibit the lysosomal enzyme which is responsible for the joint destruction. So basically they are helpful in controlling the acute attack. So allopurinol is a drug of choice in chronic gout. Mechanism of action is it inhibits the xanthine oxidase, thereby it prevents the conversion of the hypoxanthine to xanthine and xanthine to uric acid. So the active metabolite is the alloxanthine. So even allopurinol, to produce its action to get converted into alloxanthine, it requires the xanthine oxidase. So febuxostat is allopurinol is a purine analog, whereas febuxostat is a non-purine xanthine oxidase inhibitor. Those individuals who are insensitive, who are sensitive to allopurinol and not tolerating allopurinol, you can shift it to febuxostat. Then we have drugs which can increase the excretion of the uric acid from the body. Those are the recombinant uricase. We have two drugs very important, rasburicase and the pegloticase. They convert the uric acid, they oxidize the uric acid into soluble allantoin, which gets excreted through the urine. So which is the depolarizing muscle neuromuscular blocker? You know, that is succinylcholine, and succinylcholine is used for endotracheal intubation, and also it is responsible for malignant hyperthermia, and to treat malignant hyperthermia you use dantrolene sodium. So next, coming to the non-depolarizing neuromuscular blockers. Under shorter acting drugs, you have mevacurium. Intermediate, you got VCAR, that is vecuronium, cisatracurium, atracurium, rocuronium, and rapacurium. So longer acting drug, we have tubocurarine. To treat vecuronium and rocuronium toxicity, we have the drug called as Sugamadex. So neostigmine is used to reverse the actions of non-depolarizing neuromuscular blocking action, whereas to reverse the rocuronium and vecuronium actions, we need to use the Sugamadex. So what is the reason for succinylcholine apnea? So succinyl can cause succinylcholine apnea if the individual has a atypical pseudocholinesterase, thereby it decreases the succinylchol metabolism. Thereby it increases the succinylcholine activity, which is responsible for muscle paralysis leading to succinylcholine apnea. And also it can cause malignant hyperthermia. Drug of choice is dantrolene sodium. So which drug will undergo the non-enzymatic degradation of the Hoffman's elimination, that is atracurium and cisatracurium. So atracurium has got dose-dependent release of histamine, dose-dependent histamine release, which is responsible for the hypotension. So whereas the cisatracurium, which is a derivative of atracurium, it is less toxic in nature and it is preferred as a muscle relaxant of choice in case of the kidney disease, elderly and liver disease. So what happens when you give aminoglycosides? Aminoglycosides will potentiate the action of the non-depolarizing neuromuscular blocking agent, because aminoglycosides will decrease or inhibit the release of the acetylcholine from the nerve terminals. So what is baclofen? Baclofen is a neuromuscular blocker, that is a skeletal muscle relaxant, and it is a selective GABA B agonist. So baclofen for GABA B agonist. We have a thiazidine, which is centrally acting alpha 2 agonist, and it is a clonidine container. So coming to the local anesthetic, under local anesthetic you need to remember the difference between the amide linked local anesthetic and the ester linked local anesthetic. So amide linked local anesthetic example is lidocaine, bupivacaine, ropivacaine, dibucaine, and prilocaine. So how to remember amide? So all these drugs have two highs: lidocaine, bupivacaine, ropivacaine, dibucaine, and prilocaine. Whereas in case of ester link, you have only one high. So the properties of the amide linked local anesthetic are they are more intense and longer acting in nature. They rarely produce hypersensitivity reaction. They are not hydrolyzed by plasma esterases. There is no cross sensitivity with ester local anesthetic, and also it binds to alpha-1 acid glycoprotein in the plasma. So what is the mechanism of action of the local anesthetic agent? So the mechanism of action is it inhibits the axonal sodium channel. It is a sodium channel blocker in an inactivated state. So what is the dose which is required for combining the adrenaline with the lignocaine? Dilution will be 1:50,000 to 1:2 lakh. For adrenaline dilution, other dilution is 1:1,000 intramuscular injection in case of anaphylactic shock, whereas 1:10,000 for treating IV endotracheal route as well as the intraosseous route to treat the cardiac arrest. And eutectic mixture of local anesthetic. Eutectic mixture is also called as EMLA, which is made up of, there is a eutectic mixture of local anesthetic, which is made up of combination of the lidocaine and the prilocaine. So basically this kind of anesthetic are used for intact skin after surface application. So bupivacaine, it can be given through epidural route. So the congener or derivative of bupivacaine is ropivacaine. Ropivacaine has got lesser side effect than the bupivacaine. So it produces adequate analgesia without significantly blocking the motor activity. So that's why they are used in case of labor, obstetric analgesia. They're also called as obstetric analgesics. Next we have bupivacaine side effect, that is it prolongs the QTC interval. It causes ventricular tachycardia and cardiotoxic in nature. So to prevent the cardiotoxicity, IV infusion of lipid emulsion will going to reverse the cardiotoxicity. Next we have drugs from the spinal anesthesia and their complications and contraindications. Next, coming to the spinal anesthesia complications. So what are the complications associated with spinal anesthesia? We have respiratory paralysis, hypotension, neurological complication, that is CNS, dizziness, headache, confusion, delirium, etc. We have headache, nausea and vomiting, and cauda equina syndrome. So what are the contraindications for use of spinal anesthesia? So the hypotension, hypovolemia, uncooperative patient, infant and children, any bleeding disorders, raised intracranial tension, kyphosis, the lordosis, and sepsis at the injection site. All these are the contraindications for spinal anesthesia. Next, coming to general anesthetic agents. So under general anesthetic agents, please remember what is the mechanism of action of general anesthetic agents. So basically it will going to cause sedation. Basically it will going to potentiate the inhibitory neurotransmitter activity, that is the GABA A receptor gated chloride channel activity. So directly stimulate chloride channel, augment the glycine action, that is the inhibitory neurotransmitters. It inhibits the neuronal cation channels gated by nicotinic cholinergic receptor. It selectively inhibits the excitatory NMDA type of glutamate receptor, and it stimulates the potassium channel neuronal hyperpolarization. So this is the general mechanism which are mediated by the general anesthetic agent. So which among the general anesthetic agent will have a properties or characteristic of second gas effect on the diffusion hypoxia is nitrous oxide. So second gas effect means nitrous oxide will act as a carrier agent to carry the other gas. Example is the halothane. So diffusion hypoxia means, so immediately when you stop the nitrous oxide, so what will happen is nitrous oxide rapidly diffuses into alveoli, and they displace the hair, leading to diffusion hypoxia. How to treat diffusion hypoxia is treated by administering 100% of oxygen just prior to the stoppage of the nitrous oxide. So second gas effect are seen with nitrous oxide. So because nitrous oxide has got low blood solubility, 1 liter per minute will enter the blood, and it is higher than that of the minute volume. So when the nitrous oxide is given, so along with nitrous oxide, one more potent anesthetic agent, example halothane, can be carried very quickly because the nitrous oxide will act as a carrier agent for another anesthetic agents. So thereby it delivers at the faster rate and induction will be faster. So even the recovery rate will also be faster. So what is diffusion hypoxia? Diffusion hypoxia is seen with nitrous oxide. So whenever the nitrous oxide is discontinued, the nitrous oxide diffuses rapidly into the alveoli. It dilutes the alveolar air, leading to the partial pressure of the oxygen will going to reduce. So this can be prevented by administering 100% of oxygen inhalation just before the stoppage of the nitrous oxide. So one more general anesthetic which can cause the malignant hyperthermia, and the drug of choice will be your dantrolene sodium. So one more skeletal muscle relaxant which was causing malignant hyperthermia is the succinylcholine. So when we talk about the properties of the nitrous oxide has got good analgesic activity, which acts as a carrier agent, good for obstetric analgesia, dental analgesia. So only concern it, since it expands the air pockets, it can cause pneumothorax. You should be very careful. It can cause increase in cerebral blood flow and leads to increase in cranial pressure and bone marrow depression and peripheral neuropathy. So these are the side effects of nitrous oxide. So next we have a halothane. So halothane is a analgesic, as well as it has got muscle relaxant property, and also it's going to potentiate the neuromuscular blocking drugs. And since it decreases the calcium intracellularly, it causes direct depression of the myocardial contractility and causes cardiac depression. And also it sensitizes the heart to the arrhythmogenic potential or arrhythmogenic action of the adrenaline catecholamines. So basically it will going to sensitize the catecholamines towards the heart. It depresses the respiratory system on the bronchial smooth muscle. It causes bronchodilation, therefore it preferred in the bronchial asthma individuals. They are also useful in case of late pregnancy for internal and external version. Basically, it inhibits the uterine contraction and prolongs the delivery, as well as the postpartum blood loss will be less. And side effects of the halothane, you can remember H for H. It causes hepatitis and malignant syndrome, hepatitis and malignant hyperthermia. So it is used as one of the preferred drug for inducing and maintenance in case of the children. For both induction and maintenance, you can use in children. For halothane, in case of adults, only used for maintenance purpose. So basically, in general anesthesia, what happens means IV anesthetic and the inhalational. IV anesthetic used for induction and inhalational is used for maintenance. So coming to the isoflurane is a agent of choice in three conditions. Those are the any cardiac surgery, neurosurgery, and controlled hypotension. So it is used as a daycare surgery, safe in case of pheochromocytoma, and it causes coronary steal phenomenon. Next, coming to the sevoflurane, again a fluorinated compound. It is agent of choice for induction in case of children's, and it produces a nephrotoxic metabolite, that is the compound A. Inhalational anesthetic, which can precipitate the seizure or the convulsions or seizure. You can remember it as seizure. S stands for sevoflurane, E stands for enflurane, I stands for isoflurane. So how to remember the ethanol effects? So ethanol, you can write it as ethanol, and H stands for hyperthermia. It is called malignant hyperthermia. A stands for, since cardiac depression, it can lead to arrhythmias and also sensitizes the heart to adrenaline. It is hepatotoxic in nature, liver toxicity, orthostatic hypotension, tocolytic in nature. Heart, it depresses the heart rate, decreases the cardiac output. Asthma, it causes bronchodilation. It is non-explosive, and it can cause chills. In post-operative anesthetic, shivering can occur. And catecholamine, there will be increased release of catecholamines, and children's, they are safer. Halothane is safer in children's. Next, coming to the thiopenton, which is a intravenously rapid acting agent. It is an ultra short acting barbiturates. Most commonly, it is an intravenous induction agent of joints. Since it has got a property of redistribution, its action will be terminated very fastly. And they are also used as anticonvulsant agent of choice in case of cerebral protection, as it decreases the cerebral oxygen consumption, reduces intracranial tension, and reduces the cerebral metabolic rate. Apart from that, they are also used in case of accidental injection of the thiopenton can lead to ischemia and gangrene. To treat this condition, what you need to do is that you need to leave the needle in situ and dilute the injection, that is thiopenton, with the saline, and immediately you need to go for heparinization and papaverine injection. And barbiturates, please remember, though it has got abuse potential, they are not used, and they are contraindicated in case of acute intermittent porphyria. So next, coming to the ketamine. So as you know that ketamine is agent of choice in case of emergency anesthesia, that is whenever the patient is having full stomach. And it's also called as dissociative anesthesia, as the patient will not be aware of what is occurring, and patient will be awake. So it causes dissociative anesthesia. It is the patient will be dissociated towards the surroundings. It can cause hallucination, the most common. So ketamine is an NMDA receptor blocker. That is one of the type of the glutamate receptors, and it will going to increase all the pressures, like it is the anesthetic agent of choice for shock. They are contraindicated in glaucoma and head injury because it increases the pressures in all the cranial cavities. So apart from that, IV anesthetic agent of choice in bronchial asthma will be ketamine, whereas inhalational agent of choice in bronchial asthma is the halothane. And IV anesthetic agent of choice in children through inhalational route is sevoflurane. Through parenteral route, there is IV anesthetic agent of choice for induction is ketamine, and for inhalational in children it is sevoflurane. But IV anesthetic agent of choice in children for induction is the ketamine, and inhalation you have sevoflurane. So how to remember the ketamine? They are used in kids, so they are the IV anesthetic agent of choice in case of children. E stands for emergency reaction, which is a side effect for which can occur after long-term usage of the ketamine. It causes hallucination, illusion, vivid dreams. Basically, this action takes place in the thalamocortical junction mechanism of action, and you have A stands for analgesic activity, maximum among anesthetic agents. So ketamine has got the maximum analgesic property, and this can be used whenever the patient is having full stomach, that is meals can be given in case of full stomach. And also it increases all the pressure except for the intracranial pressure, intraocular pressure and the blood pressure, and they are the excellent choice of anesthetic agent in the bronchial asthma individuals. Next, coming to the propofol. So as you can see that propofol is a IV anesthetic agent of choice for daycare surgery, IV anesthetic agent of choice for malignant hyperthermia. Please don't confuse. Propofol is a IV anesthetic agent of choice in case of malignant hyperthermia, but drug of choice will remain dantrolene sodium. So dish, you can remember propofol. They are used in case of their daycare surgery. It is called as dish. Dish is the mnemonic for propofol. They are used for daycare surgery, total intravenous anesthesia, sedation in case of ICU, and malignant hyperthermia. So coming to the muscle relaxants. So which are the drugs which are preferred as a muscle relaxant during surgeries? So in case of asthma, we use vecuronium as the preferred muscle relaxant. In case of liver and kidney diseases, atracurium and cisatracurium is preferred. And for endotracheal intubation, we choose succinyl-choline. Next, we have a barbiturates and the benzodiazepine differences. So what are the important things you should remember under the barbiturates? So barbiturates, you can see that it increases the duration of the chloride channel opening, whereas the benzodiazepines will going to increase the frequency of opening of the chloride channels. So please remember, this will going to increase the frequency of chloride channel opening. So barbiturates, it increases the duration of chloride channel opening. Benzodiazepine, it increases the frequency of chloride channel opening. So barbiturate has got GABA mimetic as well as GABA facilitatory, more of GABA mimetic action. Whereas benzodiazepine is GABA facilitatory in action. As GABA mimetic means it acts directly on the GABA A receptors. GABA facilitatory means it will going to increase the activity of the GABA itself. And coming to the barbiturates, it has got anti-epileptic property as well as anesthetic property. That is, for epilepsy, we use phenobarbital is one of the drug which is used for treating status epilepticus. And anesthetic agent, IV anesthetic agent, that is thiopental. So barbiturates, when compared to the benzodiazepine, they have got narrow therapeutic index, and the steep of the DRC is very narrow or steep, and it's a powerful enzyme inducers which will lead to many of the drug interactions, and it is high abuse in liability and no specific antidotes are available. For barbiturate toxicity, what you need is which is a weak acid, you need to go for alkalinization of the urine. It can be done by the sodium bicarbonate. Coming to the benzodiazepines. So benzodiazepines, as you can see here, it increases the frequency of chloride channel opening. It is mainly GABA facilitatory in action. Where do we use benzodiazepines? We use as a hypnotic and sedative agent, anticonvulsant, anti-anxiety, skeletal muscle relaxant. Skeletal muscle relaxant, in case of febrile seizure we use febrile seizure. We can use in case of the febrile seizure in case of the children's. So we whenever there is a toxicity with respect to the benzodiazepines, you have a benzodiazepine receptor antagonist that is called as flumazenil. Whereas in case of the barbiturates, we don't have any antidotes. So only the benzodiazepine has got flumazenil as the benzodiazepine receptor antagonist, and bicucline is the non-competitive antagonist for benzodiazepine. So what are the advantage of the benzodiazepine over barbiturates? Very important. So benzodiazepines have got flat dose response curve. It is high in therapeutic index, less hangover. It has got less deep distortion in the DRC. It has got less abuse potential, and also less drug induction. That is they don't have a enzyme inducing activity, or they are less in drug interaction. Coming to the newer hypnotic. So as you can see here, the newer hypnotic. So these are also called as Z drugs. Please remember, these are also called as Z drugs. That is, we have a zopiclone, zolpidem, and zaleplon. So the mechanism of action is it stimulates the GABA A receptor, and prolongs the stage 3 and 4 sleep, and does not affect the rapid eye movement sleep. The advantage is they are less rebound insomnia. They causes less rebound insomnia, less hangover, less abuse, and mainly used for short-term insomnias. So what are the drugs which are used for insomnias? We have Sevorexant, we have Lemborexant. So they are the orexin receptor antagonist. Next we have drugs like melatonin receptor agonist. Please remember, melatonin receptor agonist, that is the Ramelteon and Tesamelteon, which are used for long-term sleep onset insomnia. And advantage is no addiction, but disadvantage being it causes hyperprolactinemia. So melatonin receptor agonist, they causes hyperprolactinemia, basically used for long-term sleep onset insomnias. So next, coming to the Parkinsonism. So under Parkinsonism, this is the diagram which is very important to remember. So we have a very important drug, that is the you can say drug of choice or preferred drug in the treatment of Parkinsonism will be your levodopa. So whenever you give levodopa in the periphery, it undergoes conversion into the metabolite like dopamine. So dopamine is an active metabolite, and this active metabolite will not cross the blood-brain barrier. So you need to increase the concentration of levodopa so that you make sure that it will not convert it into the dopamine. And if it gets converted into the dopamine, so how levodopa will be converted into dopamine? With the help of dopa decarboxylase. So it decreases the concentration of levodopa, increases dopamine, and this dopamine is responsible for side effects such as postural hypotension, arrhythmia, and vomiting. And also it undergoes the degradation with the help of COMT enzyme into the metabolite. And if you increase this L-dopa, how you can increase the L-dopa concentration? By inhibiting the COMT activity by giving the entacapone and talcopone. Talcopone has got both peripheral and central activity. Entacapone has got peripheral activity, and talcopone is highly toxic in nature, liver toxic in nature. So to prevent dopa decarboxylase activity, you use carbidopa and benzerazide. Thereby you increase the levodopa concentration, which will going to increase the entry of the levodopa into the brain. So once levodopa concentration increases, it can cross the blood-brain barrier easily. In the brain, what happens? It gets converted into dopamine with the help of dopa decarboxylase. And you may ask that whether carbidopa will cross blood-brain barrier. Carbidopa will not cross blood-brain barrier. So that's why it connected to dopamine is an active form, and this act on the receptor and is responsible for treatment of Parkinsonism. Again, COMT is responsible for its active further metabolite, and MAO-B is responsible for metabolism of dopamine. To increase the concentration or availability of dopamine, you can inhibit the tolcapone, that is an inhibitor of COMT, and you can inhibit the monoamines B activity with the help of selegiline and resergiline. And also, if there is increase in dopamine activity on the D2 receptors, what will happen is that there is overactivity that leads to dyskinesia and behavioral changes. So this is one of the side effects of the levodopa. Levodopa. And to increase the receptor activity itself. So these are the dopaminergic agonists. We have a pramipixole, ropinirole, bromocriptine, and the pergolide. So next, remember that always levodopa has to be combined with carbidopa to increase the efficacy of the levodopa in the treatment of Parkinsonism. So what are the adverse effects of the levodopa? So please remember this schematic diagram. So levodopa, since it triggers the chemoreceptor triggers, it can cause nausea and vomiting, which can be decreased by carbidopa. Again, D1 stimulation will lead to vasodilation, postural hypotension treated by carbidopa or reduced by carbidopa. And beta 1 stimulation will lead to arrhythmia and palpitation. Again, it can be reduced by carbidopa. And levodopa, it stimulates the alpha 1 activity, causes hypertension, decreased by carbidopa. And also through alpha 1 stimulation, it can cause mydriasis and contraindicated in glaucoma. And also it can cause dyskinesia, where you can use amantadine and levetiracetam for the treatment of dyskinesia. And it can cause psychotic symptoms. They are not decreased by carbidopa, but they are improved by giving a atypical antipsychotic, that is clozapine and the quetiapine. So basically all these side effects is mainly due to the peripheral conversion of levodopa to dopamine, and this is the culprit which is causing all this side effect. So next, coming to the other important concepts under the anti-Parkinsonian. So if there is an increase in the pyridoxine, which is a vitamin B12, which is a cofactor for the synthesis of a dopa decarboxylase activity. So what happens if they consume the pyridoxine? Some question will arise like this. So the patient was put on levodopa, and simultaneously, because of the vitamin deficiency, he was put on a vitamin B complex, and later there was a reduction in the beneficial effect with respect to the levodopa. So what could be the reason? So all this vitamin B complex or pyridoxine, which is vitamin B6, is a cofactor which will increase the activity of dopa decarboxylase, and this increased activity will lead to conversion of levodopa to the dopamine, and which will lead to decreased effectiveness of the levodopa in case of Parkinsonism. So for the long term side effects of levodopa, that is the long term administration, can lead to wearing off effect and on and off effect, and these are having shorter T-half. And to decrease the wearing off and on and off phenomenon, what you need to do is you need to go for the longer acting dopamine agonists like pramipixole, ropinirole, bromocriptine, and pergolide. These are having lesser tendency to cause the wearing off effect and the on and off effect. And you should be very careful when you are using the levodopa, as levodopa abrupt withdrawal can lead to neuroleptic malignant syndrome, and it can increase the risk of peptic ulcer, increase the risk of active bleeding. It can, since it is a melanin pigment is present and it is derived from the melanin, so it can be causing malignant melanoma. So L-dopa is a precursor of melanin. So catechol methyl transferase inhibitor, we have tolcapone, which is longer acting but hepatotoxicity at the same time. Next we have a MAHO B inhibitor, that is resergiline and selegiline. They are the reversible MAHO B inhibitor. When you use these drugs, you can reduce the dose of levodopa and also decrease the abnormal movement which is seen with the levodopa. And high doses, what it does is it inhibits the MAHO A also, where it will be responsible for cheese reaction. So basically resergiline, selegiline, MAHO B inhibitor will going to decrease the abnormal movement and decrease the disease progression. So next, coming to the dopamine agonist, which are used for the treatment of Parkinsonism. In case of dopamine agonist, we have a ergot derivative and non-ergot derivative. Coming to the ergot derivative, we have bromocriptine pergolide, but pargolide is having cardiovascular defects, cardiovascular defect. So whenever we talk about the ergot alkaloids are responsible for vasoconstriction and vasospasm, and also responsible for fibrosis, there is pleural fibrosis, peritoneal fibrosis, and cardiac fibrosis. So what about the non-ergot derivatives? Non-ergot derivatives, we have pramipixole and ropinirole, which are longer acting in nature. Only problem with respect to the dopamine agonist of non-ergot derivative is excessive daytime sleepiness, and it can lead to impulsive control behavior, that is pathological gambling, as well as hypersexuality. So please remember, now we use the non-ergot derivative or the first choice of drug for treating the Parkinsonism over the levodopa because of the lesser side effects, and it is very longer acting in nature. Next we have a rotigotine. Rotigotine, they are used as a transdermal patches in the treatment of Parkinsonism, and the discontinuation, when the rotigotine is discontinued, there can be high risk of formation of the crystals. So next we have a amantadine. Amantadine is antiviral drugs, and now they are used in the treatment of Parkinsonism also. Along with antiviral activity, it has got anticholinergic, antiglutaminergic activity. So basically, amantadine will going to increase the presynaptic dopamine release and inhibit the reuptake. Thereby, it will going to increase the dopamine levels. Only the limitation factor for the use of the amantadine is it can cause ankle edema and libido reticularis. Next, coming to the selective adenosine, that is selective adenosine A to A receptor antagonist, that is the estradephylline mechanism of action is selective adenosine A to A receptor antagonist. So what is the activity of adenosine? Acts on A2 adenosine receptor and inhibits the D2 receptor function by dopamine. Here this action will be reversed. So basically they are useful for treating off episodes in case of Parkinsonism. So what are the treatment for drug-induced Parkinsonism? So what are the drugs which can induce the Parkinsonism? You have antipsychotic agents, we have metoclopramide, etc. So how to treat the drug-induced Parkinsonism? In case of drug-induced Parkinsonism, D2 will be blocked and the concentration of acetylcholine will increase. Cholinergic activity will be more. To treat this cholinergic activity, you want to use the centrally acting anticholinergic agent. So we have 3 B's, that is the benzaxole, piperidine, and benztropine. The benzaxole is also called as the triaxiphenydyl. And to treat the drug induced, that is you need to have a drug which is having potent anticholinergic activity, that too central anticholinergic activity. We can use first generation antihistamics like promethazine, diphenhydramine, etc. So and also you can use orphanadrine. So these are highly antimuscarinic in activity. So what are the drugs which are used for treatment of Alzheimer's disease? So in the Alzheimer's disease treatment, we use the drugs like donepezil, rivastigmine, and galantamine. And also in addition, you can use memantine, which is a NMDA receptor antagonist. So these are the newer anticholinesterases. Next, coming to the anti-epileptic drugs. So anti-epileptic drug is very easy to remember. So the mechanism through which the anti-epileptic drug will act is either it will going to prolong the inactivated state of sodium channel, that is the sodium channel blockers, potassium channel openers, decrease the glutamate activity, that is the excitatory neurotransmitter, increase the GABA activity, increase the glycine activity, which are the inhibitory transmitter, and it blocks the T type of calcium channels, and we have miscellaneous. So in one word, what we can see, this is the action which is mediated by the phenytoin, carbamazepine. So all this activity are seen with the valproate. Valproate has got the multiple mechanism of action, whereas phenytoin and carbamazepine have mostly the sodium channel blocking activity. So the drugs which are prolonging the sodium channel in an inactivated state are the phenytoin, carbamazepine, valproate. We have the newer drugs like lamotrigine, lacosamide, topiramate, and zonisamide. So potassium channel opener, we have ezogabine and topiramate. And drugs which will decrease the glutamate activity are the lamotrigine, topiramate, felbamate, and perampanel. So felbamate will going to block NMDA receptors, and perampanel will going to inhibit the AMPA receptors. So drugs which are increasing GABA activity are the valproate. After the valproate, we have topiramate, thiagabine, barbiturates, and benzodiazepines. And the drugs which are blocking the T type of calcium channel is valproate, ethosuximide, and the zonisamide. So we have a miscellaneous group of drugs, that is the levetiracetam, which is a synaptic vesicle 2A agonist. We have a gabapentin and pregabalin, which is a calcium channel. It binds to the calcium channel. Lacosamide binds to the CRMP2 inhibitor. Cannabinoids, they are the cannabinoid 1 receptor agonist. So this is the diagrammatic representation of the mechanism of action of different anticholinergic agent. So as you can see here, this is the voltage gated channel which will be inhibited by phenytoin, carbamazepine, valproate, lamotrigine, lacosamide, topiramate, and zonisamide. And on the other hand, potassium channel opener, we have azogabine, topiramate. We have the drugs which can bind to calcium, that is gabapentin, pregabalin. We have thiagabine, which inhibits the activity of the gate transporter, and we have levetiracetam, which acts on the synaptic vesicle 2A protein. And basically, when this is activated, there will be release of neurotransmitters, and neurotransmitters released here on the other side is the inhibitory, on the other side is the glutamate, that is the excitatory. This GABA will be inactivated with the help of GABA transaminase. To inhibit these activity and increase the GABA levels, we give a vigabatrin, which is a inhibitor of the GABA transaminase activity. And these GABA which is staying will act on the postsynaptic membrane on the GABA A receptors. So this benzodiazepine and barbiturates will going to facilitate the GABA activity. On the glutamate side of the neurons, so glutamate will act on the AMPA receptors, and parampamil will inhibit the AMPA receptors. We have azogabine and topiramate, which acts on the potassium channels. We have a calcium channel blocker, that is T type of calcium channel blocker. The example is the ethosuximide. So next, coming to the drug of choices. So please remember, phenobarbital is a drug of choice for treating the GTS in infants, and drug of choice for status epilepticus is the lorazepam, and drug of choice for febrile seizure is the rectal diazepam. So please remember, what is the drug of choice for absence seizure? Drug of choice for absence seizure is valproate. If the age is mentioned as less than 2 years, then the drug of choice will change to ethosuximide. The reason being, valproate is hepatotoxic in nature. Next, coming to the phenytoin mechanism of action, side effects, and their uses in one chart. So phenytoin mechanism of action is it blocks the sodium channel in an inactivated state. They are used for GTCS, partial seizures. It follows saturation kinetic. Initially it will have a first order, later it get converted into the zero order. So there is a container of the phenytoin, that is phosphenytoin, which is more water soluble and prodrug of phenytoin, and it will going to be administered through slow IV infusion and IV, and basically helpful in case of status epilepticus, where the side effects will be very less when compared to the phenytoin, especially the injection site related side effects will be less. And next, we have a adverse effects reaction can be remembered in the form of the mnemonic, that is Hart Malika. H stands for asceticism, hypertrophy, that is gamma hypertrophy. O stands for osteomalacia, because of decreased vitamin D as well as calcium absorption from the gut. Teratogenicity, that is fetal identoin syndrome, characterized by PCM, that is a hypoplastic phalanges, cleft lip, cleft palate, and the microcephaly. And megaloblastic anemia can occur due to the decreased folic acid absorption. CNS related side effects, it can cause nystagmus ataxia, it can cause lymphadenopathy, it causes hyperglycemia because it inhibits the insulin release, and vitamin K deficiency, it causes leading to increase in bleeding risk and arrhythmias. And so at toxic plasma concentration, you're going to see the cerebellar side effects like ataxia, vertigo, nystagmus, and diplopia. Please remember phenytoin. Phenytoin is a potent enzyme inducer, and this is responsible for drug interaction. Whenever you give along with the other drug, this inducer will going to increase the metabolism of the other drug. So what will happen if you give uh, 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 rifampicin in case of rifampicin rifampicin if you give a what will happen if you give a rifampicin with oral contraceptive? There will be oral contraceptive failure because rifampicin is a potent enzyme inducer. It decreases the concentration of the oral contraceptive pills, that leading to oral contraceptive failure. Next we have a carbamazepine. So again the mechanism of action is similar to that of the phenytoin. It blocks the sodium channel. Drug of choice for the partial seizures and trigeminal neuralgia. Also they are useful in neurologic conditions, that is glossopharyngeal neuralgia, herpetic neuralgia, used as adjuvant in case of bipolar disorders and as an antidiuretic agent. Although it is teratogenic in nature, it should be cautiously used in case of pregnancy. It can cause teratogenic effect. So what are the side effects of carbamazepine? So it can cause CNS related side effects like the dizziness, headache, ataxia, vertigo, and diplopia. And there is a high risk of formation of rashes, leukopenia, aplastic anemia, Steven-Johnson syndrome, and hepatotoxicity. All these side effects are less with oxcarbamazepine, which is a congener of carbamazepine, and it has got less chance of autoinduction, weak enzyme inducing capacity, and hepatotoxicity. This has got the autoinduction. Please remember, carbamazepine has got own metabolism, so it is called as autoinduction. It induces its own metabolism, which are not seen with the oxcarbamazepine. But with respect to oxcarbamazepine, hyponatremia risk is more, but whereas in case of the carbamazepine, hyponatremia is very less in nature. So next, coming to the whole concept of the valproic acid. Valproic acid has got multiple mechanism of action. So as you can see, it will block sodium channel, increases GABA activity, it inhibits T type of calcium channel, it inhibits the decrease the glutamate activity. Please remember, among all the anti-epileptic drugs, it is potent enzyme inducers, as well as it is the most toxic drug. It is the most toxic and teratogenic drug. So you never combine valproate with carbamazepine because both of them will lead to hepatotoxicity. So where we can use these kind of drugs. So this is the drug of choice in case of GTCS, myoclonic seizure, atonic seizure, absence seizure, clonic seizure, tonic seizure, and Lennox-Gastaut syndrome. Since, as we told, it causes teratogenicity, you need to supplement with the folic acid to prevent this congenital birth anomaly like neural tube defect. So what are the side effects of the valproate? It can be remembered as valproate. V stands for vomiting, alopecia, liver damage, pancreatitis, POCD, R for rashes, obesity, very important, agranulocytosis, tremors, epigastric pain, and hyperammonia. So please remember, in case of the liver damage, especially if it given in case of children, in case of absence seizure, hepatotoxicity will occur with the valproate. So here the drug of choice will remain as a ethosuximide. So apart from these, they are also used for as adjuvant therapy in case of bipolar disorders, migraine prophylaxis, trigeminal neuralgia, tardive dyskinesia. It's a drug of choice for bipolar disorders with rapid cyclers. So valproate are used in bipolar disorders with rapid cycles. So what is the drug of choice for convulsion during labor, that is during eclampsia? Drug of choice during pregnancy will be the magnesium sulfate. So what are the relatively safer anti-epileptic agents? That is carbamazepine and lamotrigine. But to treat the eclampsia in case of pregnancy, use the magnesium sulfate. So next we have a status epilepticus. So how to treat the status epilepticus? As you can see, if status epilepticus will be named only if the seizure activity is more than 30 minutes, if there are 2 or more seizure activity, and without any recovery of the consciousness. So what you can do is initially you start with the drug of choice. The drug of choice for status epilepticus is the lorazepam. If it is not controlled, you go with diazepam. And next go with fosphenytoin. If not available, go to phenytoin. And not responding, you go for phenobarbital, that is barbiturates. So all the refractory cases which are not responding to lorazepam, fosphenytoin within the 40 hours onset of seizure, you will need to shift it to the phenobarbital. So if it is not working out, you can give IV midazolam, propofol, and the thiopentol. So as you can see that lorazepam, why it is preferred over the diazepam, it is more sustained action, low lipid solubility, slower redistribution, less thrombophlebitis. Whereas diazepam action fades off after 20 minutes, repeated doses required, and damages the vessels when injected. So fosphenytoin, whenever you give, it's a water soluble form of the phenytoin. It has got longer acting drug, and ECG monitoring has to be done. So phenytoin, when compared to fosphenytoin is safer, and phenytoin, it increases the risk of local vascular complications. So these are the drugs you need to remember. One is lorazepam, fosphenytoin, phenobarbital, and the midazolam, propofol, and the thiopentol. Next we have a antipsychotic agents. So next, coming to the antipsychotic agents. So based on the insight, if the insight is present, we call it as psychosis. The example for psychosis is schizophrenia, mania, depression, bipolar disorders. And if the insight is present, we call it as neurosis. Under neurosis, you have got obsessive compulsive disorder, phobias, anxiety, eating disorders, bulimia, post-traumatic stress disorders. So what happens in case of schizophrenia? Schizophrenia, there is a increased dopaminergic overactivity in the limbic system. So there will be dopamine activity will be excess. So you need to block the dopamine. So we have typical antipsychotics and atypical antipsychotics. So let me remember this concept very easily. So typical antipsychotic will predominantly block D2 receptors. Apart from that, it also blocks 5-HT2A, alpha, muscarinic, and histamine, but predominantly it is alpha 2. Predominantly it is D2. Whereas atypical antipsychotic, it predominantly block the 5-HT2A receptors. It can also block the other receptors also, but predominantly 5-HT2A receptor, but weak D2 receptor activity. It is a weak D2 receptor blocking activity. And a typical ones, since it blocks the D2 receptor, it is more prone for extrapyramidal side effects and the hyperprolactinemia, and it has got weak D2 blocking activity. EPS is less, and hyperprolactinemia risk is very less with atypical antipsychotic. That is, the galactorrhea, gynecomastia is less with the atypical antipsychotics. Whereas the weight gain, metabolic syndrome are more commonly seen with the atypical antipsychotics. And please remember, positive symptoms are well treated by the typical ones, whereas negative symptoms will be treated by the atypical antipsychotic. But typical antipsychotic will effectively remove the positive symptoms, whereas the atypical antipsychotics will remove both positive and the negative symptoms. So basically, in case of positive symptoms, there will be activation of the D2 activity, increase in D2 activity in the mesolimbic system, whereas for negative symptoms to arise, there will be increase in 5-HT2A activity in the mesocortical system. So which is the drug which is preferred for resistant schizophrenia? So resistant schizophrenia, we use the clozapine, that is the atypical antipsychotics. So how to remember this typical and the atypical antipsychotics? So we have three groups of drugs, that is the phenothiazine, butyrophenones, and thiothixans. Under phenothiazines, you have derivative based on the side chain, that is aliphatic, piperidine, and piperazine. So we have chlorpromazine, thioridazine, flufenazine. Buterphenone, we have alloperidol. Thioxanthines, we have flupentixol. We have a atypical antipsychotic, that is COX, Zara, that is the clozapine, olanzapine, quetiapine, zotiapine. We have zipradisone, aripiprazole, risperidone, and the amisulpride. So antipsychotic, as you can see with the diagram, basically this chlorpromazine, which is a typical antipsychotics, It is mainly blocking the D2 receptor. Again, even chlorpromazine can block D2 receptor because the haloperidol, flufenazine, and thiothexane are predominantly blocking D2 activity. So whereas clozapine will block the predominantly 5-HT2 activity. So what are the side effects which will going to arise from the antipsychotic action? Antipsychotic action. As you can see here, uses the positive symptoms. Example is hallucination, delusion. They are in the mesolimbic system. This occurs in mesolimbic system because of increase in the dopamine activity. So typical antipsychotic here will going to help the patient. For negative symptoms to get relieved like emotional blunt, apathy, attention, and cognitive impairment, which occurs in the mesocortical region basically due to increase in 5-HT2A receptors, we can use atypical antipsychotics. It will going to relieve both the positive as well as the negative symptoms of schizophrenia. And also it has got anti-emetic activity except for aripiprazole. So basically it blocks the D2 activity on the CTZ and prevents nausea and vomiting in the medulla. Apart from that, what are the side effects? So what are the uses? So it can be used in case of the schizophrenia, antiemetic agent, therefore it prevents nausea and vomiting. It can be used for intractable hiccoughs, refractory depression as an adjuvant agent, for tetanus, alcohol hallucinations, and the anti-anxiety to reduce the anxiety. So what are the side effects which are associated with the antipsychotics? So antipsychotic, very main thing, since it blocks the D2 receptor, it is more prone for extrapyramidal side effects, more with first generation, less with the second generation antipsychotics. So EPS, we have acute dystonia, which is earliest to appear, akathisia, which is most common, Parkinsonism, next tardive dyskinesia is the late. So mainly because of increase in cholinergic activity. So acute dystonia is due to the increase in cholinergic activity. There is a increased movement. Akathisia, there is a irresistible desire to do a movement. So we have a benzexol. Akathisia, we have propranolol. Parkinsonism, again we have benzexol. And to treat the tardive dyskinesia, so you need to use VAMT, vesicular monoamine inhibitors like valabenazine and deutetrabenazine. So apart from EPS, we have side effects related to anticholinergic, like there is a blurring of vision, urinary retention, constipation, dryness of the mouth. Exception is the clozapine, which causes hypersalivation. It is also called as, it causes wet pillow syndrome, which is seen with the clozapine due to hypersalivation. So apart from that, it also blocks the alpha activity. So because of that, it can be prone for orthostatic hypotension and there can be lightheadedness. Since it blocks H1 activity, it causes sedation. D2 blocker in the pituitary, it causes increase in prolactin release. This is responsible for galactorrhea and gynecomastia in case of the male and females. There can be sexual dysfunction. So these are the general side effects of the antipsychotics, especially more towards the typical antipsychotic, where EPS will be more, anticholinergic activity will be more, H1 blocking activity, alpha 1 blocking activity, D2 blocking activity will be more. Whereas the atypical antipsychotics, EPS will be less, it will be more prone for agranulocytosis, especially the clozapine. So that's why weekly monitoring should be done. And metabolic complications are more with the clozapine. So it can cause weight gain, hyperlipidemia, diabetes. But the metabolic complications are less with risperidone. But risperidone has got important side effect, that is the hyperprolactinemia because of high D2 blocking action. It also increases the risk of stroke, and it is the first line drug now. And apart from that, hypersalivation seen with clozapine, it can decrease the seizure threshold and precipitate seizure. And olanzapine will also have a metabolic complications. Along with it, it also increases the risk of stroke. And olanzapine is a potent antimuscarinic agent. You can expect the side effects which are related to the antimuscarinic activity. Next, coming to the quetiapine. Again, quetiapine is a atypical antipsychotic. It causes metabolic syndrome, postural hypotension. It is due to the alpha 1 blocking activity. And very important, QT prolongation will occur with quetiapine. there's a QT prolongation, arrhythmia can occur. So even other drugs which can cause QT prolongation along with quetiapine is the aripiprazole and the ziprasidone. Aripiprazole and the ziprasidone. We have amisulpride, which can lead to hyperharmonia. So along with the QT prolongation, this ziprasidone has got additional useful activity by inhibiting the reuptake of the serotonin and the noradrenaline, which is similar to that of the antidepressant. So ziprasidone can be used as anti-anxiety drug as well as the antidepressant drug. So the main side effects which are related to the atypical antipsychotics are the hyperprolactinemia, more seen with the risperidone, QT prolongation with quetiapine, aripiprazole, ziprasidone and amisulpride, agranulocytosis, hypersalivation and the myocarditis with the clozapine. So antipsychotic side effects based on their CNS property. So it causes sedation, H1 blocking activity, it increases the risk of seizures. Cardiovascular system blocks alpha receptor, postural hypotension is more, inhibit ejaculation, QT prolongation. So anticholinergic side effect, dryness of the mouth, constipation, urinary retention, blurring of vision, but clozapine will cause hypersalivation. So endocrine uses D2 blocking will cause hyperprolactinemia, lead to galactorrhea and gynecomastia. So metabolic related side effects will be with a weight gain, that is obesity, increase in sugar levels, that is diabetes, and increase in triglyceride levels. So risk are more with olanzapine and the clozapine, and low with the RAS, that is risperidone, aripiprazole and ziprasidone has got low risk potential. Even EPS is more with the first generation compared to the second generation. Miscellaneously, there can be a risk of blue pigmentation on the skin, which are mainly seen with thioridazine. Apart from that, rarely you can see cholestatic jaundice, photosensitivity reaction, skin rashes in the urticarias. So next, coming to the mechanism of action of the lithium. So lithium is the drug which is used for treatment of the bipolar disorders. So what is the mechanism here? It will going to inhibit the inositol monophosphatase, thereby it inhibits the inositol monophosphate synthesis. Thereby there is no free inositol will be available for supply. So therefore there will be decrease in secondary messengers IP3 and diacylglycerol, leading to decreased hyperactive neurons. So lithium, very important. So what is the dose which is required? Because of the narrow therapeutic index, it has got narrow therapeutic index, safety level is less, the drug dosage, therapeutic dose will be 0.5 to 0.8. 0.5 to 0.8 is the maintenance, 0.8 to 1.2. So please remember, 0.5 to 0.8 is the maintenance dose, 0.8 to 1.2 milliequivalent is the acute mania dose. So if the dose increases more than 1.5, it leads to toxic symptoms which are related to coarse tremors, giddiness, ataxia, motor incoordination, CNS side effects like mental confusion, nystagmus, slurred speech, etc. And also you should remember that how to remember the lithium in the form of mnemonics. So there is an increase in the leukocyte count. This is the side effect. Tremors can occur is the most common side effect. It can lead to fetal hypothyroidism or congenital hypothyroidism, increased in urine secretion, and it causes diuretic activity, nephrogenic diabetes insipidus, where amyloid is a drug of choice for the lithium-induced diabetes insipidus. And avoid in case of pregnant mother because it causes Epstein's anomaly as the side effect, which will the cardiovascular side effect, which will going to affect the tricuspid valve. So always remember, there are some drugs which will get excreted through the saliva. One such drug is the lithium, get excreted through sweat, saliva and the breast milk. And also please remember, lithium when combined with thiazides, what will happen? Again, there is a lithium toxicity. Why lithium toxicity? This thiazide will going to increase the lithium absorption from where? From the proximal convoluted tubule. The reason being, the body will treat sodium as a lithium. That's why there will be absorption of the lithium instead of the sodium from the proximal convoluted tubule, leading to the toxic effects. If the dose is more than 4 milliequivalent, you need to go for dialysis, that is the hemodialysis. And carbamazepine valproate never combined because of their hepatotoxic in nature. and they are used as a manic depressive psychosis bipolar disorders. Again, this is one of the drugs which are used to treat the manic bipolar depressive psychosis. This lithium is also called as anti-suicidal drug, anti-suicidal drug. So Epstein anomaly. So overdose, that is more than 4 milliequivalent, you go for dialysis. So lithium can cause Epstein anomaly, especially heart is affected, that is tricuspid atresia. It can cause floppy infant syndrome when taken by mother. It can cause fetal goiter, that is congenital hypothyroidism. Next, coming to the antidepressant drugs. Antidepressant drugs. What happened in case of depression is there is a decrease in the brain derived natriuretic factor, and there is a decrease in the monoaminergic activity. So there will be decrease in serotonin as well as noradrenaline activity that has led to the depression. So what you need to do is you need to increase the 5-HT and increase the noradrenaline concentration at the synaptic junction. So there are group of drugs which can increase the serotonin and noradrenergic activity. They are called as typical antidepressants. Under typical, we have drug which are blocking MAHO inhibitor and those drugs which are inhibiting reuptake inhibitor. So MAHO are the one which will going to degrade the 5-HT and the norepinephrine drugs. So this will be the enzyme which is responsible for breakdown of the 5-HT and the serotonin. So we have a non-selective MAHO inhibitor and selective MAHO A inhibitor. We have non-selective trinylcypromine, isocarboxide and phenelzine, and selective MAHO A inhibitor we have a moclobemide. Under reuptake inhibitors we have two kinds, again a non-selective and a selective, and again non-selective will be 5-HT and both the noradrenaline reuptake will be inhibited. We have very important drug, that is the tricyclic antidepressants. We have imipramine and amitriptyline. We have SNRIs. We have venlafaxine, duloxetine and the milnacipran. Under selective, that is SSRI, selective serotonin reuptake inhibitors, we have fluoxetine, paroxetine, fluoxamine, sertraline and the citalopram. So when do you expect the cheese reaction to occur? Whenever the patient consumes cheese, beer or red wine, and the patient is on non-selective MAHO inhibitor, this food material will contain rich of tyramine content, which is indirectly acting sympathomimetic agents. So because of this, the non-selective MAHO inhibitor, these tyramine will escape degradation and responsible for increased catecholamine release, leading to the hypertensive crisis. So what is the drug of choice for cheese reaction is the phentolamine, which is a alpha blocker. So when do you expect serotonin syndrome? So serotonin syndrome will occur if you give a selective serotonin reuptake inhibitor just after discontinuation of the MAHO inhibitor. It can cause serotonin syndrome. So to avoid this phenomenon, always start SSRI at least 14 days after the MAHO inhibitor discontinuation. Is that clear? Okay. Next, coming to this is again a diagrammatic representation of showing the reuptake inhibitor. So SNRI TCA will inhibit the norepinephrine reuptake as well as the serotonin reuptake. So TCA SNRI plus SSRI will block the uptake of serotonin as well as block the uptake of the noradrenaline. And MAHO inhibitor will inhibit the breakdown of noradrenaline and the serotonin. We have miancirine and the mirtazapine will going to inhibit the alpha 2 activity, thereby it will going to increase the activity of noradrenaline release. We have a 5-HT receptor, that is the trazodone and the nefazodone. So next, coming to the tricyclic antidepressants. So tricyclic antidepressant mechanism of the action is it inhibits the reuptake of serotonin and noradrenaline. So basically used for long-term administration. So what will happen once you administer a drug for long-term? There will be desensitization of the receptors and increased transmission will occur. And this to cause a desensitization of the receptor, it takes longer time. There is a long latency of 2 to 3 weeks for the TCS to act as well as SSRI to act. So what are the side effects of the TCA? So we have a sedation due to H1 blocking activity, lower seizure threshold, weight gain is very important classical of TCA, powerful anticholinergic agent, weak alpha 2 antagonist, and cardiac arrhythmias. So safety margin of the TCA is very low. Uh, what will what to give in case of tricyclic antidepressant overdose? So in case of overdose, what happens? There can be cardiac arrhythmias, hypotension, anticholinergic signs, and CNS symptoms. To treat the tricyclic antidepressants overdose or toxicity, you need to inject IV sodium bicarbonate, and this will take care of the TCA cardiotoxicity. And lignocaine is a drug of choice for TCA induced ventricular dysarrhythmias. So IV fluids are used to treat the hypotension, diazepam used to treat the convulsion, and physostigmine is antidote for tricyclic antidepressants. So SNRI, when compared with the TCA, SNRIs are much more safer and drug of choice for severe depression. So what are the other first line drugs uses which are available for SSRI? So selective serotonin reuptake inhibitors can be used as a first choice of drug, the treatment of depression, phobia, obsessive compulsive disorder, post-traumatic stress disorder, bulimia, premenstrual tension syndrome, and panic attacks. So what is the advantage to use SSRI as a first line drug? There is no anticholinergic effect, no sedation, no weight gain, no seizure threshold decrease, no arrhythmia. So these are the advantages which makes SSRI as the first choice drugs. So what will be the side effects of SSRIs? It can cause nausea, vomiting, anxiety, diarrhea, and CNS headache, insomnia, and also it inhibits the ejaculation and it causes anorgasmia, and co-administration with the MOHO inhibitor leads to serotonin syndrome. So in general, antidepressants uses, or they are used for treating depression, aneurysms, that is bedwetting. Imipramine is used, but drug of choice will be the desmopressin, which is a vasopressin analog. P stands for phobia, R stands for recurrent panic attack, eating disorder, smoking cessation, bupropion, stress disorder, impulse disorder, obsessive compulsive disorder, and then neuropathic pain. Apart from that, we have atypical antidepressants. We have 5-HT2 antagonists, that is trazodone and nefazodone, presynaptic alpha 2 antagonists, that is the miancin and mirtazapine. Those drugs which increase the presynaptic release of the catecholamines, we have bupropion, basically used for cessation of smoking with varenicline and nicotinic patches. We have serotonin reuptake enhancer, that is tianeptine and amинeptine. 5-HT1 agonist with serotonin reuptake inhibitor, we have otioxetine and velazodone. We have selective noradrenaline reuptake inhibitor, that is atomoxetine. We have NMDA antagonist, that is esketamine. So now, next coming to the morphine. Morphine is opioid analgesic. Under this, you need to remember the uses, contraindication, and the adverse effects. Uses: they are used as analgesic agent for treating visceral, dull, and constant pain. But you should remember they are contraindicated in case of biliary colic. It can be used to relieve the myocardial infarction pain. It can be used to reduce the pulmonary edema by shifting the water from the pulmonary circulation to the systemic circulation. So it can use as a cough suppressant in the form of codeine, used in non-infective diarrhea, that is loperamide and the diphenoxylate, as a pre-acidic medication to decrease the pain as well as anxiety, and pethidine is used to decrease the shivering. So what are the side effects associated with morphine? As you know, it is a CNS depressant, and also it causes respiratory depression. It causes nausea and vomiting. It causes constipation, urinary retention, dysphoria. Tolerance will occur to all except for very important all three C's, that is the constriction of the pupil, meiosis, constipation, and the convulsion. And it is highly addictive in nature. Withdrawal will lead to withdrawal syndromes leading to rhinorrhea, lacrimation, chills, yawning, mydriasis, and diarrhea. And also you should remember, it should not be given in asthma patient because it causes bronchoconstriction. So contraindications, major contraindications are head injury because it increases intracranial pressure, and also in case of renal hepatic dysfunctions. So where do we use methadone? Please remember, methadone is a longer acting opioid analgesics. It blocks the NMDA receptor. That means it blocks the glutamate. It blocks the glutamate activity. It inhibits the reuptake of monoamines. But very classical use of methadone is for opioid abuse as well as to prevent the withdrawal symptoms. Withdrawal symptoms because they are longer acting when compared to the other opioids. So longer acting. So for use for opioid abuse, prevent the withdrawal symptoms. So next we have pethidine and pentazocine. So pethidine and pentazocine has got anticholinergic property, and this is responsible for tachycardia, and that's why they are contraindicated in MI, but safer in case of biliary colic. Pethidine and pentazocine, they are safer in biliary colic. And we have opioid antagonists such as, you need to remember, one is the naloxone, naltrexone, nalmefene. Naloxone is a drug of choice for opioid poisoning, and we have a naltrexone, which is a drug used for maintenance drug for opioid poisoning and to prevent the relapse after the de-addiction. And also it reduces the craving in alcohol. Naloxone for acute opioid poisoning, naltrexone for maintenance drug opioid poisoning and prevent the relapse. Methadone is used for maintenance therapy in opioid dependence. Opioid dependence. So apart from that, what you should need to remember is the important uh, diuretic used as antihypertensive agent is your thiazides. So with related to calcium, loop loses calcium, that's why there is a hypocalcemia, and also there is a increased risk of calcium stones. Whereas the thiazide will going to retain calcium and causes hyperkalemia. So apart from that, you have a potassium sparing diuretics. Under that you need to remember SEAT, SEAT. So SEAT stands for the spironolactone. Next we have eplerenone. Next we have amyloride. Next we have triamtrin. But this has got high affinity towards testosterone receptor or androgenic receptor. This is responsible for gynecomastia. So eplerenone is devoid of gynecomastia because it has got less affinity towards the androgenic receptors. Amisulpride, as you know, it is a drug of choice for lithium induced diabetes insipidus, and also spironolactone is the one which will going to increase the disease survival rate by decreasing the cardiac remodeling in case of congestive heart failure patient. Apart from that, what you need to remember, mannitol is used as a osmotic agent. We have carbonic anhydrase inhibitor like acetazolamide, and mannitol is a osmotic diuretics. We have anti-diuretic agents. So we have the V2 receptor mediated action, V1 mediated. V2 receptor is the diabetes insipidus, and diabetes insipidus we have central and the nephron or renal related nephrogenic. Central diabetes insipidus drug of choice is the desmopressin, And neurogenic or the renal, you have a thiazide. Thiazide can be used for both central as well as the renal. So V1 related, it can be used for esophageal varices. Apart from that, is also used for bedwetting, etc. Apart from that, you have a drug which can block the antidiuretic action. We have drugs like conivepton, mozavepton, etc. Basically, they are used to treat the hyponatremia in CHF. They are the antidiuretic. They are the vasopressin receptor antagonist. Conivepton, mozavepton, etc. So apart from this, what you should remember is the what are the drugs which can cause ototoxicity with respect to the diuretics. So it is usually the furosemide loop diuretics. Loop diuretics will be used for the treatment of the anasarca because of their quick and brisk action. So these are some of the very important drugs that can be asked in your exams that you should remember. So what is the drug of choice for OP compound poisoning? So one is the drug of choice will be your atropine, and next you have a enzyme reactivator that is oximes, prylidoxime, etc. So you can, again, the atropine will be the drug of choice in case of carbamate poisoning, but not useful. Oximes are not useful because in case of OP compound there is two sites. One is the ester site and anionic site. This ester site will be combined with the OP compound and this will be vacant, and to this vacant the oximes will come and attach. But whereas in case of the carbamate, both the site will be occupied by the carbamate. There is no vacant thing which is available. So these are some of the questions which are very important from the general pharmacology, autonomic nervous system, ANS, PNS, local anesthetics and general anesthesia, CNS, diuretics, etc. So these are the things you should remember. One thing you should remember is, again, which is the diuretic which is preferred in treating diabetes insipidus of renal origin or nephrogenic origin. Please remember it is thiazide due to paradoxical action. Hope this will help you in terms of revising these topics in solving MCQs, as well as it helps in doing some of the long essay questions, short answer questions, as well as MCQs as well. So hope this will be helpful for you during exam times for revision. And if you like this video, please do subscribe to my channel. I love pharmacology, and do not forget to share and hit the like button for more updates on pharmacology. Thank you.